And I would like to introduce Amanda Green, has worked at VCU Health CMH in rehabilitation as a physical therapist for 7 years. She obtained her bachelor's in recreational therapy from East Carolina University and doctorate in physical therapy from Winston-Salem State University. She has a certification in vestibular rehabilitation, which refers to balance in the inner ear. I will turn it over to her.
Hello, everyone. I'm Amanda. I'll be doing the talk today. So we'll be talking about dizziness and vertigo, some tips and tricks from a physical therapist. All right, so first off, I just want to discuss the difference between dizziness and vertigo. So first off, what is dizziness? So the definition of dizziness, it refers to lightheadedness, feeling of passing out or blacking out, unsteadiness or loss of balance, floating, swimming, or a feeling of heaviness in the head. So these indicate that the condition may not necessarily be vestibular in nature. Now, when we say vestibular in nature, we mean coming from the inner ear. Still possible, but not as likely. So them saying some things that are good to know. The older you are, the more likely you are to experience dizziness. And dizziness is the #1 complaint in individuals 70 and older. So some diagnoses that cause dizziness. You have cardiopulmonary issues, issues referring to the heart and lungs, anyone with high or low blood pressure, psychiatric, so sometimes it can be psychiatric in nature, pharmacologic, so medication can play a part in a cause of dizziness, toxicity, so exposure to different chemicals can make you feel dizzy. Cervical, sometimes dizziness can be referred from your neck. And then diabetes can also cause dizziness as well. So vertigo,
slides.
the definition of vertigo.
I don't know how. Go to your
The definition of vertigo is a sensation of motion in which the individual feels a sensation of internal or external spinning. So a lot of times people will say that they either feel like the world around them is spinning or they feel like they are spinning.
There's something called mirror.
These indicate that the condition is vestibular in nature, meaning it is coming from your inner ear. But in most cases, good news, physical therapy can help. So some common diagnoses that cause vertigo, one of them, which we're going to talk about today, the first one, you have benign paroxysmal positional vertigo. We're going to talk about that more later. There's vestibular neuritis, Meniere's disease. You have stroke, concussion, or any sort of head injury. Individuals with migraines can also experience vertigo. You also have mal-debarquement syndrome. So this syndrome is what you feel if you've been on a cruise ship and you come off and you still feel like you're moving along to the waves of the boat. There's actually a definition or name for that condition. And then there's chronic intractable motion sickness. So first, I want to talk about with vestibular diagnoses. They can either be labeled as a hyperfunction or a hypofunction. So hyperfunction means you have one ear that's good, that's doing what it should, and then you have another ear sending the brain an overload of information. So it's the opposite for hypofunction. You have one ear that's good, and then the other ear is not sending enough information to the brain. So with the hyperfunction, with vertigo, these symptoms only last typically for a few seconds or minutes, and the symptoms are with changes in the head or body position. With a hypofunction, the symptoms will typically last longer than a few minutes or seconds and can last up to a couple hours. These individuals report vision changes, they have imbalance, especially with head turns, and they also report difficulty walking outdoors, in crowds, and in dark rooms. So here I have a picture of the anatomy of the ear. So when we talk about the inner ear, we're going to talk about this organ right here. All right, so here is the organ that sits in the inner ear. It consisted of the cochlea, which is the bottom portion here. So this portion actually helps with your hearing, and everything above is your balance center. So you have these little organs down here and these 3 canals. So what does the vestibular system do? Its primary function is equilibrium. It assists with spatial orientation for knowing where you are in space. It senses gravitational changes, and it senses movement of velocity changes as well. All right, so again, with the organ here, where there's 2 little, there's some organs that sit down here at the below these little canals here. You have your utricle and saccule. Their job is to detect sensitivity and changes in gravity and linear acceleration. So if you ever heard of anyone talk about crystals in their ear, so those little crystals or otoconia actually stay in the utricle and saccule, and the shifts of those otoconia send the signal to the brain about gravity and linear changes. So here we have the picture again. We're going to talk about these 3 canals. You have your anterior canal, you've got the posterior canal that sits more towards the back, and the horizontal canal that sits around here. So the job of the canals is to sense changes in velocity. So inside these canals, you have fluid and hair cells. So anytime you move the head up, down, left, or right, the fluid in the inner ear will shift. And this change of the fluid will also cause the hair cells to move. And whichever direction those hair cells move, tell the brain where you're moving in space. So we also, the cerebellum actually plays a part in the vestibular system and your balance as well. It helps with coordination, motor learning, posture, balance, and it does communicate closely with the vestibular system. So I'm going to talk about 3 reflexes here, one of which we're going to talk about more later when we come to treatment. We have the vestibular ocular reflex, or your VOR. So this reflex keeps your eye movement steady when you're turning your head and neck. So if you're talking to someone and you're engaged in the conversation and you're agreeing and you're nodding your head up and down, you're able to keep your eyes focused on that individual instead of your eyes moving up and down with your head. You have your vestibular spinal reflex. So this assists with postural control and maintaining your center of gravity. It also helps with returning to and maintaining head and body in neutral positioning. And then you have your vestibular colic reflex. This assists with head and neck stabilization. So one of the diagnoses that I talked about earlier was DPPV. This is one of the most common vestibular disorders people will experience. So with the BPPV, as we talked about earlier with the organ here at the inner ear, you have your utricle and saccule, which house those otoconia or crystals. And then you have the 3 canals here with the fluid and the hair cells. So with BPPV, what happens is one of those otoconia or crystals ends up leaving here and entering into one of these canals. So one ear, you're turning your head to the right. One ear is telling the brain that you're turning your head to the right. The other ear, with one of these canals, happens to have one of those otoconia lodged. So you're turning your head. So instead of the hair cells moving in a fluid direction, that otoconia is causing those hair cells to move up, down, left, right, all around. So this ear is sending mixed information to the brain. The brain gets confused as where you are and where you're moving in space, and that's why you start getting that spinning sensation. So some things that are good to know: the half of individuals over 70 will experience BPPV. Older adults with BPPV are at higher risk for depression, falls, and decreased activity tolerance. So those with osteoporosis, diabetes, and vitamin D deficiency have an increased risk of BPPV. This is because with osteoporosis, the calcium, the otoconia actually consist of calcium. Your bones consist of calcium. So without osteoporosis, that calcium breaks down, your bones become more brittle. So do these otoconia in the ear. Those crystals will start breaking down and break off into smaller pieces and are more likely to be lodged and escape into one of those canals. With diabetes, if uncontrolled, the fluid that is in those canals can become thicker. So if one of those crystals does happen to become lodged into one of the canals, it's harder for it to escape. So same kind of going hand in hand with osteoporosis with the vitamin D deficiency. If you can't absorb enough calcium, then the otoconia in the inner ear are smaller, they're more brittle, and they'll escape easier. Also, if you are dehydrated, the fluid in the inner ear will become thicker, and this will also make the symptoms worse. So individuals after a motor vehicle accident, any sort of brain injury or fall or head injury, you are more likely to experience BPPV as well. There are a couple tests for vestibular impairment. So I've broken them up because the tests for BPPV are completely different for other tests with vestibular impairment. So the test over here on the right are all for those conditions that I labeled as a hypofunction, meaning one ear is not operating as fast as the other. So on the right for BPPV, I'm going to go through each one of these tests later with a video to show them. On the right, some other tests that we could do is a head thrust test. So this head thrust test will actually test that reflex, that VOR reflex that we talked about earlier. You have the convergence test, which is going to test your vision. You have your dynamic visual acuity, which will look at your ability to stare at a target or read while moving your head up and down and side to side, and looks at your vision. And then we also have balance training. So types of treatment for vestibular impairment. The top one, the canalith repositioning maneuvers, are just for BPPV. So we also have gaze stabilization. We have habituation exercises, adaptation exercises, substitution exercises, and as well as general balance training. So testing for BPPV. So these tests are will be done by a therapist or a clinician in the office if you start reporting symptoms of BPPV. All right, so the first test here, the Dix-Hall Pike, is going to test your anterior and posterior canals. I'm going to play the video. So as you can see, you would start off sitting on the mat with your legs out straight. You'll be assisted laying back with your head tilted to the ear that the therapist or clinician wants to test. You would stay there for about 30 seconds. The clinician is looking at your eyes during this time. The direction or movement of your eyes is going to indicate which one of those canals affected. If you have BPPV, this test is going to cause your eyes to go into a movement called nystagmus, and that nystagmus is what your therapist is looking for. So our next test is a modified version of that test. So if you're an individual that has neck pain, you can't tolerate laying on your back, you've had neck surgery and you don't have enough range of motion to tilt your head back, you can do this test performed in sideline. So I'm going to play the video. So the person is laid on their side with their head turned away from the ear that you want to test. So they're laying on the side of the ear you want to test. Again, you're watching for that eye movement. If it happens, if it does happen, it's positive, and the direction of the eye movement would indicate to the therapist which of those canals is affected. So this one is your supine roll test. So this test is going to test for just that horizontal canal. I'm going to play the video. So this test, you would quickly turn the head left and then you would turn the head right. You would hold each position for about 30 seconds. And again, you're watching for that eye movement. And if the eye movement comes on, it will tell you that that person's positive, and then the direction and speed of the eye movement versus left and right would let the therapist or clinician know which ear is affected. This test, again, say you can't lay on your back, or you don't have that much range of motion in your neck, or you have neck pain and you can't tolerate moving your head that quickly. This test also tests the horizontal canal, and you're just laying on your side for this test. So you would lay down on your side, the therapist or clinician would watch for that eye movement again, and they would be able to tell if it's positive and which ear is affected. Okay, so treatment for BPPV. So these treatments would also be performed by your therapist or a clinician if it's indicated if any one of those tests were positive. So the first one is the most common people know of, is the Epley maneuver. This maneuver would actually treat posterior canal involvement. So I'm going to play the video. It's going to start off in the same position as that Dix-Hall-Pike maneuver. You're going to have their head turned to the side you're treating. You would hang out for about 30 seconds in each position. You would then turn their head to the other side, wait 30 seconds. The individual would roll on their side and you would tilt their head down even further, wait 30 seconds. And then the individual is assisted sitting back up. You would sit with your head down for about 30 seconds. And then you would look straight ahead. And at the end of each of these treatments, you would sit looking straight ahead with no head movement for 5 minutes. The next one is the Samantha maneuver. So again, if you can't tolerate laying on your back, you can't tolerate those extremes and rotations of your neck, this maneuver will still treat that posterior canal involvement. So you would start off at the same positioning as that modified Dix-Hall-Pike positioning. You would assist the person to lay down on the side you want to treat with their head turned away. You would wait about a minute or two here. And then you would assist them laying all the way over on the other side. You would then tuck your chin to your chest with the forehead down and wait another minute or two. Sit back up with head down 30 seconds. And then again, you would sit with your head straight ahead, not moving for 5 minutes. This next maneuver is the Gans repositioning maneuver. So it's going to still start off in that modified Dix-Hall-Pike positioning, but it's going to look a little different from the maneuver we just saw. So I'm going to play. You're still going to lay down on the side we want to treat. Head is tilted back. Hang out for 1 to 2 minutes. Then from here, without moving your head, the person is rolled over to the other side, chin tucked to their chest and head down. Again, wait here 1 to 2 minutes. Then the individual is assisted back up, head down for 30 seconds. And then they would be sitting looking straight ahead for 5 minutes with the head not moving. Okay, this maneuver treats the anterior canal. So it's gonna do just like the name says, it's the deep head hanging maneuver. You would have the patient or the individual would sit long-legged and lay back on their back. And you're bringing their head back as far as you can. And you just hold their head back for a minute or two, bring their head up all the way towards the chest as far as you can. We'll wait there for a minute or two, come back up with the head down, and then look straight ahead. Now, if an individual cannot tolerate that positioning to treat the anterior canal, you can always complete one of the ones previously, but just switch and do the opposite side instead of starting out on the side that the ear is affected. You would lay on the opposite side. So if you were treating the right ear for anterior canal involvement, you would have the person start off laying on their left side versus the right. So if you wanted to treat the horizontal canal, there are different treatments and maneuvers for the horizontal canal. I like this one because you don't have to know which ear is affected to be able to do this maneuver, because this maneuver will treat both ears. So you would have the individual start off in that same position as the test. Once you see eye movement, you can then go right into the treatment. You would bring their head up towards the ceiling. You would wait there about a minute or two, and then they would turn their head all the way down to the mat with the chin tucked. Wait again. Then the head is brought back up, and then the person is asked to roll on their other side. Wait there. Head is moved back down. And then they're assisted back up into sitting with the head down for about 30 seconds. And then they would look straight ahead for 5 minutes. Okay, so these next exercises are treatment for the hypofunction vestibular rehabilitation. So just as a precaution, please don't try any of these at home. Make sure that you're doing these under the supervision of a trained therapist or physician. So first off, we have just regular balance training. So here we have the individual standing on a foam surface. This just mimics standing on different compliant surfaces, like if you were standing on sand, uneven ground, gravel, and being able to balance in those situations. So here she's standing on a rocker board. So this simulates standing on those moving or types of surfaces. So around this area, so if you're on your boat or on a dock, it's constantly moving with the waves. This would simulate that same type of motion and being able to balance in those situations. Here she's standing with one foot in front of the other, so she decreased her base of support, making it harder for her to balance. And here we're doing the same exact thing, but now on foam, which is further challenging her balance. So here are some exercises. We talked about that VOR reflex, the vestibular ocular reflex. So if you're an individual that has dizziness and it's difficult for you to walk around the grocery store and look left and right and look at the aisles and what's on either side of the aisles, these are exercises that would work for people with those issues. So here we're starting off with head turns. She's staring at a target straight ahead. She's keeping her eyes focused on that target, but as you can see, she's moving her head left and right. Now, the speed that the person would turn their head would be told by the therapist. All right, so here we're still testing, I'm treating that VOR impairment, but now instead of just the head moving, she's staring at the target here that is also moving. And then now we're gonna, if you persons with difficulty nodding their head up and down, keeping their eyes focused on a target, we would do this direction, up and down, keeping eyes focused on the target. Again, the speed of the movement would be directed by the clinician and the therapist. And then again here, instead of just the head moving, you have the card, object, and the head moving together in opposite directions. All right, so you can combine the VOR exercises with your balance training. So here I have her on the foam like we saw earlier, but I'm also having her stare at a target straight ahead while turning her head. And then here, she's standing on that rocker board. She's staring at a target straight ahead and moving her head up and down. All right. And we would also progress this with walking. So this would really help those individuals that are going into the grocery store. They want to be able to walk and look down the aisle. So she's walking, turning her head left and right while looking at a target straight ahead. All right. Are there any questions?
I see 3. She's kind of difficult because she's hooked up to so much stuff.
Does anyone have any questions about anything?
Hello, this is Michelle McCurtain. Can you hear me?
Yes.
So I do have a question. So I've been through like all of this with vertigo testing, you know, moving around, and still constantly have dizziness. So how many times are you supposed to do this physical training to get, like, is it something that people who suffer with vertigo might have to do like every so often, depending on how bad their vertigo gets?
So yes, especially with BPPV, it can be recurrent. So you can go through rehab, you're cleared, you're told by your therapist everything looks good, you're feeling great, and then a couple months later, or even a year or however long later, it can return. And then unfortunately, there are those individuals that it's recurrent, like several times a year it comes back.
Yeah, I think I'm one of those.
But the goal with the vestibular rehab is that you have tools go after you're done with therapy, that if it does come back, you know what you can start working on to help it go away again or improve. There are those individuals that if it's a hypofunction, unfortunately, their dizziness can improve, but it may not 100% go away.
Right. Okay. Thanks. And I
And
guess
Dr. Green, we have a question in the chat from Carmen Johnson. If any of this would help if you experience occipital neuralgia.
It can, if you're having any vision, if you're having any troubles with gaze stabilization, being able to focus on targets, and it definitely can help. Yes.
I have a question.
Okay.
I was recently diagnosed with hearing loss and have to have hearing aids.
Yes.
Does the hearing aids affect the vertigo at all?
They shouldn't, but sometimes if it's an impairment to the nerve, sometimes the balance can be affected, and along with the hearing. So you can have both. It just depends. Is it just the hearing, or is there impairment to the nerve?
But just hearing.
Okay. Are you having any dizziness or balance issues?
Yes.
Okay. Sometimes they can go hand in hand. You can reach out to your doctor and talk to him about it, and he'd be able to direct you on what would be the best option.
Okay, thank you.
You're welcome.
I'd like to ask a question.
Okay.
I've been diagnosed with Meniere's disease.
Yes.
And the doctor told me, of course, that with the starting of it, I was really bad shape. I would actually throw up, lose your bowels, and for basically 24 hours, I never got it to bed. And he said that I was losing the hearing in my left ear, and once I lost all that hearing, I should be better. Well, I haven't experienced the Meniere's disease in a while. My hearing in the left ear is virtually gone, but I get dizzy sometimes. You know, I can be walking along and all of a sudden I just feel like I'm gonna fall. And what's your thoughts on that?
I would definitely talk to him about it and reach out to him and see if he thinks that vestibular rehab would be beneficial. I definitely think it would be beneficial.
Okay, thank you.
You're welcome.
And we have another question in the chat from Lori. If someone had one episode a year, would that indicate a referral to a PT?
Yes, it can. If they had any episode, yes, it can. So for those individuals that do have recurrent, then yes, coming into therapy, because sometimes those individuals can be taught how to do some of these maneuvers safely on their own. So if they are an individual that it comes back quite frequently, then they can have tools at home to try to see if they can resolve it on their own. But if they're not, then they come back in for therapy.
Well, thank you so much, Dr. Green. We appreciate your help, and we're at time, so we will go ahead and sign off so people can get back to their day. But if you all want to sign into our Facebook page or website, you'll be able to see this at a later date, and please share with your friends.
And thank you, everyone.